Okay, I'm showing it as 10 o'clock, so let's get started. Hello, everyone, and welcome to today's webinar, which is sponsored by the Northwest Addiction Technology Transfer Center and the Western States node of the NIDA Clinical Trials Network. My name is Meg Bruner, and I'm affiliated with both the Northwest ATTC and the CTN, and I will be your host today. So before we get started, just a couple of housekeeping things I wanted to go over. First, after today's webinar, you'll be getting an email that has a link to a survey in it. Please take the survey. It's very short and the feedback is super valuable to us. That email will also include a link you can use to download today's slides and access the recording of this webinar as well. Next, if you stay for the full webinar today, you'll automatically receive a certificate of attendance in your email. That usually takes us about a week to send out, so watch your inboxes for that. If you're watching this by yourself today, you don't need to do anything to get that certificate. We have your email address from your registration. But if you're watching with someone else or you're in a group, please send us your name and email address so we can send you that certificate. And our email is on the slide here. It's northwest@attcnetwork.org. Please don't post your email in chat. You need to send it to us via email at that address. Finally, if you have any questions during the webinar, please type them into the chat box. We'll have a Q&A session at the end, and I can read your questions to our presenters at that point. Okay, so on with the webinar. Today's topic is peer recovery support specialists as partners in research and practice, early findings from the Reducing Overdose After Release from Incarceration pilot project. Oops. Our presenters today will be Erin Stack, Senior Research Associate at Comagine Health, Elizabeth Needham-Waddell, Assistant Professor at OHSU PSU School of Public Health and Addiction Medicine Section, School of Medicine at OHSU. Christy Hildebrand, Senior Director of Research and Evaluation at Comagine Health, and Morgan Nelson from Bridgeway Recovery Services. This is the disclosure statement from our speakers, so you can read that. And then the agenda for today's webinar. Our speakers will be talking about peer recovery support services and emerging evidence, reducing overdose after release from incarceration, the ROAR pilot project, peer recovery support services in action, and then we'll have a Q&A. So with that, we will get started with Erin, who is going first today. Take it away, Erin.
Great, thanks, Meg. So as mentioned, I'll be walking us through some background on peer recovery support services. And first, I'll provide sort of a high-level overall definition of what peer recovery support services are. And then I'll get into a bit of the history of peer-delivered services. And then I'm going to step through what peer recovery support services look like across 4 different settings. So I'll give some setting-specific definitions and then provide some emerging evidence for the efficacy of peer-delivered services. Okay, so peer recovery support services are supports that are provided across the service continuum by credentialed individuals in long-term recovery from alcohol and other drugs. Titles for people that provide peer recovery support services do vary, and they include some more formal titles that are part of the titles for the credentials, things like peer recovery support specialist or peer support specialist. There's also certified recovery mentor. And then there's some more informal ways to refer to people who are providing services like peers, mentors. It really varies a lot in the literature and also organization to organization. And probably even on this presentation, our presenters will probably use varying terms for people. We're referring to the same thing. So we're referring to people who are delivering services across the care continuum, from people from harm reduction to treatment to recovery. The eligibility requirements to get certified as a peer recovery support specialist vary by state, but they typically include 6 similar requirements. So they include a minimum time in recovery. There's also a requirement of passing a criminal background check, completion of training courses, and specifically a completion of a code of ethics review. And then also there's a requirement of passing a national examination. And then the final requirement is that there's a renewal process that happens at different times depending on the state. Here in Oregon, it's every 2 years, but peer recovery support specialists are required to renew their certification in order to continue to provide services. And that can look like continuing education credits, attending trainings, things like that. So as I mentioned, peer recovery support specialists work with clients across all stages of recovery, and that includes consumers of harm reduction services. Peer recovery support specialists can offer a strong personal connection and earnest encouragement and hope for people they serve. Peer recovery support specialists' lived experience makes it potentially them more relatable than prescribing clinicians or other medical staff or social workers. The dynamic of shared experience may help to overcome some of the inherent power differentials between a clinician and client. And a big piece of peer-delivered services is that they're client-driven. So the relationship between a person that's delivering service, so between the peer recovery support specialist and the person that they're serving, can look really different from person to person because it's really based on the client needs. And that's why we actually split off talking about what they do, what peer recovery support specialists do across setting, because what the services they may provide across setting can look really different. Sorry, I jumped ahead. So I just wanted to provide a brief history of peer-delivered services. So peer-delivered services aren't new. Disenfranchised communities have turned to peer-delivered services throughout history to support things like access to care and advocacy for appropriate treatment. Peer-delivered services have been integrated in healthcare and other community settings for over 150 years. Peer-delivered services that address substance use disorder emerged through mutual aid organizations as early as the 19th century, and then they really solidified a place in substance use disorder treatment as part of 12-step programming in the 20th century. Peer-delivered service providers are defined differently across communities and settings. So an example of a peer-delivered service provider is a community health worker. So community health workers are trained healthcare team members that live within the patient's community or may share other social characteristics such as language, race, ethnicity, or culture with the people they're serving. Community health workers support patients as they navigate the healthcare system and provide emotional support and advocacy for policy change. So like community health workers, peer recovery support specialists may also share some geographic or social characteristics with the people they serve, but a key shared characteristics is the lived experience with substance use disorder. So that might make peer recovery support specialists different from other peer-delivered services. Peer recovery support services historic entrance into addiction treatment started as non-professional support roles, but it actually has emerged into being present in a lot of settings across the care continuum. And so these are the 4 settings we're going to talk about today that peer recovery support specialists are integrated in or co-located in. And so that includes community, and by community, I'll get into this a little more when I'm jumping into that, but I'm referring to things like syringe service programs or door-to-door outreach that is not necessarily connected to treatment or correctional. And then we'll get into hospitals and emergency departments, and jails and prisons, and treatment and recovery agencies. Peer recovery support specialists across settings share the same primary responsibilities that I've already mentioned. So providing hope, acting as an ally and confidant, providing motivation. A big piece is modeling behavior and offering honest and open communication, supporting decision-making and navigating resources. So that can include things like transportation or attending appointments with people. Peer recovery support specialists don't necessarily receive a certification by setting, but they often engage in setting-specific training. So what I mean by that is there isn't a specific certification for a peer to receive to work in hospital and emergency departments, but they might have additional training in a hospital and emergency department, things like HIPAA, for example, or other patient privacies based on that setting requirement. And again, their role is driven by the model of care and the needs of people receiving services in each setting. So they might look a little different providing services depending on the setting, which we'll get into in just a bit. And then across settings, challenges of implementation do arise. Some of the most noted challenges that come up in the literature are things like unclear roles, limited financial support, inconsistent boundaries, and Then also a big piece is philosophic differences between an organization and a peer model. Okay, so I'm going to get into what peer-delivered services look like in a community setting. So while it's true that peer recovery support specialists may use harm reduction and recovery and person setting orientation across settings, it's most noted in community settings where peer-delivered services are provided. And community-based outreach, peer recovery support specialists who serve people outside of the context of treatment or correction settings rely on harm reduction approaches for people with active use to reduce risk of overdose, infectious disease, and other harms of use. And peer recovery support specialists in a community setting may work with local service organizations to identify street outreach locations. They also might visit people who have agreed to have contact following an emergency medical service incident, or they might help with facilitating mobile or fixed syringe exchanges. And this is a picture of that. This is partners of ours from a different project that are showing or participating in a mobile exchange. Peer recovery support specialists in a community setting encourage positive change based on people's goals, which in this setting might look quite different than the other settings. So it often focuses on safer use of substances and decreased use, but it may or may not be linked to abstinence or linkage. Again, it's based on that client need. And then peers in this setting also assist people with daily life needs, such as accessing food, housing, identification documents, and healthcare. Harm reduction services provided can include naloxone education and distribution, fentanyl education and testing strips distribution, and access to and disposal of sterile syringes and other injection equipment. It also can include things like HIV and hepatitis C testing and linkages to care. So preliminary studies exploring peer recovery support services in community settings demonstrate positive impacts. In one qualitative study, peer recovery support specialists in syringe service programs provided increased knowledge for reducing risky use behavior. And in two other qualitative studies, participants using supervised consumption facilities reported that they felt safe when a peer recovery support specialist was present. And that safety included both physical safety, that they felt comfortable and they trusted the peer in case of an overdose, but also socially. People reported that there was a lack of perceived power, so they felt more comfortable with the peer present. People have also reported that peers encourage communication with people related to substance use disorder treatment and other social and health related needs. So they were able to communicate with peers about getting access to services to address their needs. In a randomized control trial, peer recovery support specialists in harm reduction agencies increased access and engagement with hepatitis C treatment and HIV treatment. Okay, so jumping into what peer-delivered services look like in hospital and emergency departments. So peer recovery support specialists in hospital and emergency departments may be fully integrated in or they may be co-located, meaning they may work for a local treatment agency and then go to the hospital when there's a need, when there's an overdose, or they may be fully integrated into the hospital. And in healthcare settings, they connect people to medications for opioid use disorder, intensive outpatient, social services, or harm reduction services. Peer recovery support specialists in healthcare settings are members of an interdisciplinary care team, and they're there to provide support for people during treatment of medical and surgical complications of substance use disorder. So again, that can be following a non-fatal overdose or a car accident or potentially a serious bacterial infection. And they're there to be the bridge or to translate information and provide context between healthcare providers and people with substance use disorder. And that can be beneficial for both groups of people. So it's proven to be beneficial for healthcare providers that are providing care and also the people that are receiving care. Integrating peer recovery support specialists within medical treatment may help overcome some historical mutual distrust between healthcare workers and people with substance use disorder. So for hospitalized patients, peer recovery support specialists may offer a trusted voice through a lens of lived experience at a time of heightened motivation for change. So when an individual experiences a complication that lands them in the hospital or emergency department, it can be a heightened motivation for change, and peers are there to help navigate that with the patient. And then also in hospitals and emergency departments, peer recovery support specialists can facilitate culture change within healthcare systems through knowledge sharing, modeling, and exemplifying that people with substance use disorder can successfully maintain recovery and serve as valued team members. An important thing to note that in healthcare settings, it does present unique challenges for integrating peer recovery support specialists. Things that can include are things like rigid professional structure of hospitals, stigma and discrimination against people with use disorders, inconsistent staff assignments, and then a fast-paced work environment with high patient demand. Emerging studies that demonstrate positive outcomes for peer recovery support specialists in emergency is following emergency medical calls. So in one exploratory program evaluation, people who use drugs receiving peer recovery support services in the emergency department had high levels of engagement with peer recovery support specialists following emergency department visits. And another evaluation of peer recovery support specialists connecting with overdose survivors in emergency rooms, survivors reported high rates of engagement with peer recovery support specialists and engaged in overdose prevention education, naloxone training, and peer recovery support counseling services in all of the follow-up surveys. A randomized control trial examining the impact of peer recovery support specialists follow-up in community demonstrated that if a person was assigned a peer, they engaged in medication for opioid use disorder and received more days in treatment than a control group. And then in another observational study, the median numbers of days to medication for opioid use disorder initiation following the emergency department event was shorter for a person who interacted with a peer. And patients in these settings have described peers as trustworthy, making a hospital more tolerable for patients, and it also in rebuilding trust in healthcare system. So the next thing I'm going to talk about is peers that provide support in jails and prisons. So here is a picture of a mural that's at Coffee Creek Correctional Center, which is where the ROAR program, which we'll talk about just in a little bit, is being implemented. And so when peers are providing support in jails and prisons, they support community reentry and adherence to community corrections requirements. So the transition from incarceration back to community can be a really stressful one, as people are reconnecting with their families and friends and children that they may or may not have had connections with for the time that they were incarcerated with. And so the peer recovery support specialists in jails and prisons, they can include reach-in visits, which I know Morgan and Christy will get into what that looks like in just a little bit. Some emerging findings from the jail and prison settings are participants, but people receiving services report high satisfaction with peer support. There's also higher levels of increased life satisfaction when talking about quality of life. And exploring some administrative data, there's been people that participate in peer-delivered services have decreased emergency department visits and also decrease in substance use, recidivism, and stress. Also, people who have received peer-delivered services while they're incarcerated or following incarcerated have increased self-efficacy and perceived social support and report more positive relationships with family and friends and higher quality of life. Okay, and then the last setting I'm just going to talk through briefly is treatment and recovery agencies. Treatment and recovery agencies, again, the peer recovery support specialists will be maybe integrated within case management teams, so they're part of the care team to provide wraparound supports for an individual. They're engaged in part of the support planning, and they're there to address some non-clinical needs. A big piece of peer recovery support specialists providing services in treatment and recovery agencies is the shared connection to recovery communities. So that can look like attending group meetings together, or participating in other group activities together, like social or physical exercise activities. So connecting to healthy alternatives while engaging in recovery. And then there's also peer recovery support specialists that are integrated into recovery community organizations, or RCOs. And some of the following findings from these settings are individuals that receive services have decreased use and increased abstinence from use. They also increase on recovery goals, such as housing stability, increasing the number of primary care visits, and increase levels of recovery capital. And then other things that have decreased are things like hospital visits, emergency department visits, and detox utilization. It's also been reported decreased in criminal charges and reduced reports of anxiety and tension. So there are some important considerations that I'm going to touch on here, but I'm seeing I'm a little over my time, so I know that Christy will mention these as well. So I'll go through these pretty quickly. Some important considerations to mention across setting are things like supervision. That it's a stressful job to be a peer recovery support specialist, and it's a unique position to be in. So adequate supervision is really important in order to maintain a healthy workforce and provide continuous support for people that are delivering services. There's also, as mentioned, it's a difficult position to be in as an individual's in recovery themselves and providing services. So there's high rates of compassion fatigue and burnout. And then there's a big discussion now in the peer delivered services community about reimbursement for peer delivered services. So that can include, so right now Medicaid does cover some services, but it's not fully covered, and what they cover may not fully relate or fully align with peer delivered service providers and what their intention is. And then another big piece is low wages and role definition. There's pretty unclear, in different organizations, there can be unclear roles, and peers may not do jobs that they're not trained for, or might be overlapping with other areas of the service agency. And so those are things that are important things to consider when implementing peer delivered services. And now I'll pass it over to Liz to talk about the ROAR project.
Hi, everyone. Sorry about that. Thank you, Erin, for that fantastic overview of peer support specialists. I am going to give a really brief overview of our ROAR pilot project, which is currently entering its third year. So this is a partnership between a lot of different organizations and the Oregon Department of Corrections. We developed the project with the only women's prison in Oregon, which is Coffee Creek Correctional Facility, because we wanted to learn more about the feasibility, acceptability, and effectiveness of extended release naltrexone in a population of women, particularly at risk for overdose in the weeks and months following their release to community. We are focusing on extended release naltrexone as one of 3 medications for opioid use disorder, which is available to women to start within the correctional facility, keeping in mind that the women in this project have been opioid free for 1 to 5 to 10 years. So we did not have to worry about women becoming opioid free before getting onto the antagonist medication. And for this particular pilot project, we did not want to randomize women to one medication or another. So again, our pilot project targets women with moderate to severe opioid use disorder when they're leaving prison. Our intervention is to start extended release naltrexone prior to their release, with support both pre and post-release from Oregon certified recovery mentors. This is a CDC-funded opioid overdose prevention program. Our primary outcome is opioid fatal or non-fatal overdose. We're also looking closely at retention in community treatment for opioid use disorder and a number of other psychosocial outcomes. I am posting right now to the chat our full study protocol, which was published in Health and Justice recently, and that has all of the details about our measures and analysis plan. Okay, so what happens in ROAR? Within a week before they're released to community, the consented participants receive a single dose of extended release naltrexone, which is an injectable opioid antagonist that blocks the effects of opioids and provides protection from overdose for up to 28 days. After release, ROAR participants are supported by a certified recovery mentor who they met before release, usually with an in-person visit. During our pandemic operations, it is a secure phone call, who continues to support them in community substance use disorder treatment for up to 6 months. So what happens when they released and go to treatment? All of their treatment decisions are made individually between that participant and their clinician. Some have chosen to stay on extended release naltrexone. Some have switched to buprenorphine. Some have had the opportunity to start methadone. Some have gone on to a different recovery path that does not include medication. So the extended release naltrexone that's provided in ROAR, again, is that first shot in health services, which provides overdose protection. And then with the mentor, they're linked into services and can go on their recovery journey, whatever that looks like for them. So what's the public health impact of ROAR? We're hoping to provide really critical information on how to create interventions that prevent overdose among women, justice-involved women, who are often overlooked in the research and at extremely high risk for overdose when they re-enter community. We have a very detailed evaluation plan that includes an administrative data linkage that allows us to look at overdose events among women who were enrolled in our ROAR project up to a year after release, compared to women who were released in other counties that were not in the ROAR catchment area. So this is the first time in Oregon that we've been able to link the Oregon Department of Corrections administrative data and our Oregon Health Authority vital statistics and Medicaid data to really follow these women and see what happens in the year post-release. So as I said, the ROAR team is huge, and just a few of us are on the webinar today. Our mentors come from Bridgeway Recovery in Salem and from CODA Treatment and Recovery, which serves the Portland Tri-County areas, Multnomah County, Clackamas County, and Washington County. Some of our staff are at the OHSU PSU School of Public Health and School of Medicine, Comagine Health, and you'll hear from Christy, you've already heard from Aaron, has developed and implemented the Certified Recovery Mentor piece, and Oregon State University College of Pharmacy has been leading the administrative data linkage. So for those who are not familiar, and I know that many on this webinar are probably very familiar with all of the medications for opioid use disorder, I'll go over quickly extended release naltrexone. It's an injectable suspension. The injection goes into the muscle, top of the hip, lasts 28 days. It has been shown to be effective for treatment of alcohol use disorder, as well as opioid use disorder. Generally, a period of 5 to 7 days of abstinence is required to start extended release naltrexone. If someone is physically dependent on opioids, when they start extended release naltrexone, that could trigger a pretty nasty withdrawal. Literature shows that extended release naltrexone is non-inferior to buprenorphine for decreasing illicit opioid use once the patient starts medication. So there is probably 10 other webinars that we could do to talk about how to start extended release naltrexone. It's really tricky. We've been really lucky that most of our participants so far who have enrolled in our program have accepted that first injection in health services. So what happens pre-release? There is a pre-screening of administrative records by Department of Corrections Behavioral Health staff. We are able to offer the ROAR pilot program to women releasing to the 4 Oregon counties that are served by CODA and Bridgeway. So they do a complete review of all of the releases to see who has a substance use disorder or potential substance use disorder flag in their administrative records, which I will say is up to 80% of the women releasing from Coffee Creek. Women are invited then to pre-screen in person with a qualified mental health professional from DOC. The qualified mental health professional has a conversation with them about the ROAR project and also diagnoses moderate to severe opioid use disorder, which is a requirement for participation in the pilot. Once a participant is consented, she receives 2 to 3 in-person visits during COVID, secure phone calls to meet with the mentor, and they also receive 2 health service visits, which include about an hour of education about extended release naltrexone and what to expect from the medication, expected side effects, importance of being on birth control if they're using the medication, and talk about the importance of carrying Narcan with them as well. So they have the 2 health services visits. The second visit includes the injection of extended release naltrexone. It has happened and it's totally okay. We've had a couple of women who come to that second health services visit and for one reason or another say, you know what, this medication is not for me. We still follow them in community and let them continue working with their mentor if they want to go ahead and engage in services without the medication. So the nurse counseling visit, again, is a really important part of our pilot project. It's an opportunity for the participant to review the information with the nurse. And at that visit, she confirms her intent to receive the injection. The nurse reviews relevant medical history and draws blood for liver function tests. And she or he talks in detail with the participant about what to expect at the injection. We do another medical record review that includes the DOC medical director or other Department of Corrections MD, the DOC medical director or his designee writes the prescription for the extended release naltrexone. So all of those clinical services happen inside DOC. The first injection happens 3 to 7 days before our participants are released. There is a pregnancy test the day of the injection. We have not had any pregnancies prior to release. They do a nasal naloxone challenge using Narcan, which is an unusual way to do a Narcan challenge, but it was our solution to avoiding a needle stick for a subcutaneous naloxone challenge or collecting urine. We did not want any urine that was positive for substances that would potentially trigger an investigation. So with the nasal naloxone challenge, if a participant was with withdrawal symptoms, if she had used opioids prior to that visit, then health services could take care of her for half an hour, 2 hours until she was feeling better and sent back to housing. If we had a positive urine test, that could trigger a lot of unpleasant security activities. So this is how we were able to do it without urine and without needles. It's expensive and probably not sustainable. So observation for participated withdrawal happens after the naloxone challenge, and then of course the injection. This is a sketch of our evaluation activities that happen post-release. So Erin checks in with participants every couple of weeks, reviews their locator form, their contact information. She does an in-depth 3-month survey with them, then checks in again at 4 months and 5 months, and another survey at 6 months. A random sample of participants, about 1 in 3, are invited to participate in a qualitative interview. We don't do any cash incentives for activities that are conducted prior to release. So COVID-19 extended our timeline. Our recruitment at Coffee Creek started in June 2019, and we were hoping to wrap up with releases in December of this year. We have been delayed about 6 months because of COVID. We've gone back into the facility to recruit a couple of new participants in August. There are a lot of complications with recent outbreaks, so our recruitment may well be extended through June 2021. Community follow-up, again, the original schedule was July 19 to June 2021. We may be extended in the field until December. And so similarly, adding on that 6 months to our outcome analysis. Not going to go through all the numbers on this slide, but just to give you a sense of the scope of ROAR. To date, 158 pre-screen interviews were conducted. Of those, 57 women consented to complete the baseline interview. About half of the folks that we pre-screened did in fact have moderate to severe opioid use disorder. Once they were enrolled, we've had really good retention rates and acceptance of the medication. So 53 women stayed in the program for their second health services visit. And of those, only 2 declined the injection prior to release. So 43 of our participants followed up in community treatment. So after they were released, they registered for treatment either at CODA or Bridgeway. And 39 women completed the 3-month follow-up interview, and 36 women completed the 6-month follow-up interview. Right now, we have 5 active participants, and 52 have completed the study. This is a snapshot of the database that we are using in REDCap, and Morgan and Christy will talk more in detail about that, but I wanted to give you an idea of the level of detail that we're collecting on the interactions between our participants and the mentors. So we track the mode of encounter, the location of their encounter, and the type of service that's delivered. And we also include a notes field, and we'll be analyzing qualitative data that describes all of the activities that the mentors engage in with participants. So as you can see here, we have conducted reach-in visits for everyone. The second recent visit has happened for 46 of our participants. Sometimes they're consented too close to their release date to get that second visit. We've had a couple of women who got 3 reach-in visits. And most of the women are met at release. We have offered transportation to all of our participants, but some have declined because they have a friend or a family member, or sometimes a mentor from another program that's not ROAR picks them up to take them to housing. Most of the encounters with the CRMs have actually been through text message. It's been a really great way for our ROAR participants to stay in touch with the CRMs, and a lot of phone. So with that, I would like Meg, not me, to transfer control to Christy, and we can really dig into what happens with the peers.
Thanks, Liz. So I'm going to be talking about the role of the ROAR Certified Recovery Mentor, and I'm going to introduce our mentors. I'm going to be discussing the role of the CRM on the project. We'll talk a little bit about the onboarding and training that occurred. We'll also talk a little bit about supervision and learning collaboratives. I'm going to address some of the considerations when using peers in research and considerations when working in a prison-based setting. And then we'll end our webinar with a Q&A with one of our peers, Morgan. So I just want to introduce you to both of our peers. This is Morgan. She works at Bridgeway in Salem and Marion County. And this is Ivy, and she works at CODA here in the Portland metro area. And so first I just wanted to introduce you to both of them. And I asked both Morgan and Ivy to send me pictures of what was important to them and what represents their recovery. And as you can see, they're both, really incredible moms who love the outdoors. They love running and physical fitness, lifting weights, and they're both, the things I would want you all to know is that they're both extremely skilled in what they do, and they're just very cool, and we're lucky to have them on our project. So this is Morgan. We're going to be doing an interview with her, and Ivy. So we developed a ROAR peer model that's formal and structured visits that are intensively goal-oriented. So as Liz mentioned previously, our project has 2 components, the extended release naltrexone medication and the peer intervention. And I would say that our peer model probably differs a bit from peer support services and addictions treatment, and that we really wanted to mimic goals of initiation, engagement, and retention that have previously been highlighted with groups like the Washington Circle or with HEDIS measures. I mean, what we know is when people initiate in treatment services and engage in services shortly thereafter pretty consistently, that their retention rates go up, and that's the goal here. The ROAR model includes assisting women in establishing their transition and recovery goals and aid with assessing that ongoing safe and stable housing, along with continuing to support recovery and pro-social behaviors and addressing criminogenic risk factors. And what I mean by criminogenic risk factors are factors such as like not having a job and having either poor use or a lot of leisure time or return to substance use, or having a network of people, a social network of people that are also involved in the criminal justice system on probation or parole themselves. So we know that these are potentially risk factors for recidivism. So let's talk a little bit about the mentors. I can't say enough about how crucial and critical they are to the pilot. Our mentors provide in-reach or reach-in to the women that are incarcerated at Coffee Creek prior to release. I would say that our pilot's pretty unique in that our mentors meet with the participant while they're still incarcerated and establish rapport. As Liz mentioned, these peers are meeting 2, sometimes 3 times before release at the gate, and the goal is really to develop that connection and hopefully therapeutic alliance. So things like, I've been where you've been and I've done what you've done are important. Our mentors coordinate that day of release transportation if needed, and the key here is to link them to such treatment and community. They facilitate that initial intake, so that intake could happen at day of release. Sometimes it could happen within a couple days of release or within the first week of release, that first initial appointment. And provide ongoing mentor services to promote retention. Other peer mentor activities include what they do once released, so what the mentors are doing to support treatment as usual at Bridgeway or CODA. As Liz showed you previously, our mentors are doing a double documentation. So for their protocol, they're documenting the peer-related activities in REDCap, and then they're also documenting in their agency electronic health record. I conduct weekly calls with our WAR mentors. Our mentors also attend monthly project calls with the PI and other team members from OHSU and Coffee Creek and CODA and Bridgeway. There's learning collaboratives that happen as a result of their continuing education. This is something that Erin mentioned in terms of giving 40 hours of continuing ed over the course of 3 years. And so that's something that the project provides for the mentors. And then the mentors work really closely with Erin on those locator forms and following up with women for 6 months post-release in community. We kicked off this pilot project with intensive training for our mentors. Peers had roughly, I would say, probably about 40 hours of required city trainings on human subjects and good clinical practices. And for those of you that have been through those city trainings, you know how long they can take, and they take probably double the time if you don't have a research background and if this is new information to you. So thinking about that, if you're considering having peers join a research project, is giving enough leadway to have really intensive, robust training in place. And then we did mentor-specific training. So a couple things I want to mention here is that there was a lot of upfront training because we were going into a correctional facility. So we had, orientation and security training at Coffee Creek Correctional Facility. There was a pilot kickoff that happened at Coffee Creek, and then we did a full day of mentor training on these various topics. So we talked about criminality and pro-social behavior, so how mentors can help support the goal of pro-social behaviors in terms of like thinking of others and thinking outside yourself, this outward focus. This really aligns with the recovery principle about being of service to others. We talked a lot about social learning theory and that bridge between, to kind of cognitive behavioral therapy, really having that understanding that people learn from, observing others, imitating, modeling, and having that base kind of foundation that like criminal behavior is really a learned interaction, along with communication with others, whether that's family, friends, or other adults that are incarcerated. And understand that when criminality is present, that we're really talking about rationalizations and attitudes that are just trying to get unmet needs, right? So for these women that we're working with, trying to get their needs met. And what does also social learning theory look like in the context of community corrections? So for some women, there are stipulations of the parole that they're not to commingle with other folks that are on community corrections and what that looks like and the implications of that potentially once released. We did a lot of training on gender-specific considerations. So we talked about trauma and relationships, understanding women of color and transgender considerations, the role of sexuality, the role of motherhood, the role of stigma. We talked a lot about trauma in particular and interpersonal trauma. So childhood sexual abuse and physical abuse and domestic violence, and that women have rates higher than men. Interpersonal trauma as a violation of trust, and so what is learned as a result of a woman's perception of herself, and attachment issues that happen as a result of that, and then evidence-based practices and best course of treatment with trauma. So things like TRIM, trauma, recovery, and empowerment, seeking safety, DBT, and other evidence-based practices. And I can say to you that both treatment programs, both CODA and Bridgeway, do a phenomenal job at having manualized curriculum, providing evidence-based practices in their treatment programs. They just do really top-notch work. And just overall, like this idea that relationships matter, trust is huge, emotional connection is valued, healing and growth for people occur through connection and attachment. And, almost in a little woo-woo psychodynamic way, that, the role of the mentor can really be reworking trust and developing, practicing, having, supporting, and trusting relationships with other females. We also did a bit of training around co-occurring disorders and looked at the rates, what we know with folks with use disorders have higher rates of depression, anxiety, and especially with women having eating disorders. We also talked about suicide, and both Morgan and Ivy are very skilled at conducting suicide risk assessments. We talked about PREA, which is the Prison Rape Elimination Act, and other mandatory reporting. So for those of us that are going into correctional facilities, understanding that PREA is defined by sexual abuse of an adult who's incarcerated by another adult who's incarcerated, or sexual abuse that occurs to an adult who's incarcerated by a staff member. And there's a zero tolerance policy across all of Oregon Department of Corrections. And so we were all mandatory reporters. We conducted the training, and we also knew who to contact if there was a report that happened while the woman was incarcerated or after she was released. And the other last thing that we did that Liz mentioned is that review of naloxone administration and distribution. So, all of our peers carry nasal Narcan. Our participants are released with Narcan along with their discharge medications. And so that notion that the peers need to kind of constantly remind our participants, hey, do you still have Narcan? Did you use it? Did you give it away? Do you need some more? In talking about Oregon's Good Samaritan laws too, that reminding the participants that if they're released with Narcan, but that if someone overdoses, call 911, use Narcan, and when folks show up to, whether that's police or EMS, that they can't be arrested or prosecuted because they're in possession or around someone with paraphernalia or an overdose. One of the things we do for ongoing CEUs is a learning collaborative. So we've done topics such as using destigmatizing language and advocacy, trauma and compassion fatigue, harm reduction when working with corrections populations. So thinking about that in terms of you're working with an individual who may have a mandate to not use. And so how do you promote harm reduction if there is return to use? I mean, we want people to stay safe and alive, right? Self-care for mentors is huge. I can't say enough about this. If you are working with mentors, you know this, like to constantly revisit with your peers, with your mentors, what are you doing to continue to promote your own recovery, to provide self-care? You're in a profession where you're giving a lot, and how are you filling your cup back up? And then something that both Ivy and Morgan are pros at is engagement strategies. So engaging women and engaging what sometimes can be a hard to reach population. I would even say post-COVID. So I'll give you an example. Ivy did a phenomenal job engaging women once COVID hit, that for folks that we were kind of sheltering in place here in Oregon, as I think most all states were. And so Ivy would send care packages to some of our participants with activities that she knew that they were interested in. So whether that was cross stitch or art, she had created these care packages. It was just such a lovely idea to be able to send those and say, hey, I'm thinking about you. I know we can't meet, we can't talk or see each other as much. Know that I'm here. Future learning collaboratives are going to be around recovery capital, there we go, and forensic peer model supervision. And we're also going to do a deeper dive in consideration working with transgender and non-conforming individuals. So one of the things that we did during our kickoff was provide CRMs with help sheets or quick reference guides. So when we did the full day training with the CRMs only, we talked a lot, and it's a lot of information, and it's, mentors know treatment. They know treatment like the back of their hands. They know community partners and what's available to them. But when it comes to protocol stuff, I think people just need a constant reminder. So we developed an elevator speech. So if someone at any point in time, a parole or probation officer said, hey, tell me about ROAR, they could easily have this reference guide and talk about what ROAR is. We gave a screenshot around how to log back into REDCap. If you don't use a system consistently, it's hard to to remember how to log back into it. So we did screenshots about how to log back in, how to pull up a record, how to document that record. We had things like, just conversion from standard to military time, and then just I like this visual from Pew, just medications for opioid use disorder basics, and looking at the differences between methadone, buprenorphine, and naltrexone. We also provided mentors with a flow chart. So it's color-coded based on if it's Coffee Creek, based on if it's the mentor, or based on if it's someone from Comagine. And it shows the flow of how someone gets through from what Liz was mentioned previously, that early screening, to meeting with health services staff, to the reach-in visits with the mentors, to day of release. And then last, just an outline of each of the visits, each of the reach-in visits 1 and 2, and kind of topic areas that might be good to discuss during that time. And then what happens day of release and what happens week of release. And I would say that both Morgan and Ivy have adapted these specifically to talk about their role and specifically to talk about their treatment programs. So first reach-in visit, they talk about ROAR. They talk about, have you ever had a mentor, what a mentor is and isn't. They share their own experience, strength, and hope, and they tell a bit about their story. And then they talk about treatment in the community and what to expect and what it might look like. For that second in reach, they're talking about what happened since the last time we chatted. Has anything happened? Has your release changed that you know of? What's been going on? What will help them feel supported with their upcoming transition to the community? They talk with the participant about, do they have any concerns about that first day out or that first week out? Is anything making them nervous or keeping them up at night? Are they excited? Do they have any return to use triggers, or do they have like what we used to call relapse prevention plan, but return to use prevention plan? We remind the participants during that second in-reach visit that they're going to get Narcan along with their discharge meds, and ask them, hey, do you want us to meet you at the gate at release, or do you want us to meet you in treatment? Do you need a ride? And have they signed up for Oregon Health Plan yet? So during day of release, if the participant chooses, we'll meet them at the gate, offer support and hope, and begin the process of obtaining the records, so the records can get signed from DOC and be sent that show the extended release naltrexone, and the liver panels can be sent to the treatment programs. Now, we've changed this process a bit post-COVID, but bear with me. And then also looking at providing transportation. So one of the first things that when we get released from prison that they need to do is typically go sign in with a parole officer. So a lot of times we'll provide that ride and support during that activity. Some women released without clothes, without food, and our mentors are helping bridge that gap to services. Week of release, we're coordinating our contact information. A lot of women, once they get out, don't necessarily have a phone the first day, so we're keeping in contact with family members to try to make connections. We will pick them up and take them to their first treatment appointment if appropriate. And we can provide outreach and support face-to-face, text, or phone. And as Liz mentioned, and as you saw, most of our ladies appreciate a text message. So some of the considerations when working with peers in research, I would say, lots of upfront training. I can't say enough about this. Train. If you are awarded a research project in October, please don't anticipate starting that in November. Give yourself 3, 4, 5 months of upfront training. It's really important too. What we found is to have feedback from the mentors. Who are the people boots on the ground that are doing the work? Because they're going to tell you if it's going to work or not. And so to be able to tweak, make modifications if necessary. Supervision is a must. So our mentors not only get clinical supervision at their agencies, but also I provide supervision to the ROAR protocol each week. So we just kind of constantly talk about how the protocol is, has there needed to be any adjustments or changes? How are things going? In ongoing support, I would say that a lot of times my check-ins with the mentors also include like, hey, how are you doing? How is your life doing? Let's roar aside, how are things going in your world? And then I think this is key to have peers up front and in the front row of being involved with manuscripts and presentations. And having this constant discussion around the differences between the protocol and the clinical work. So I think that at times there has been what they might do in treatment, we might have offered them yes, we need you to follow up in a different way because now this woman is pregnant, right? So there's just times that I think the protocol and the clinical work, not necessarily conflicted, but we might have tweaked or done something a tad differently. Considerations for working in a prison setting, checking my time here, okay. When you're working in a correctional facility, number one thing, you're always a guest. You're always a guest, you're always a guest, and just the way in which you move about the facility. I think it's important to learn facility culture and what that means around how to move about, how to understand that safety is at the forefront every time. So what you may do in your treatment agency, at your hospital, in your research group, in the way that you behave or act is very different, and you feel it and you see it and you know it as soon as you walk in. Understanding prison lingo like kite and books and SEG and the IRS, which is the inmate rumor system. That was a new one for me. I just found that one out. Just knowing that anything can and will change, because this is a housing unit that you may show up intended to do an in-reach, and when you pulled up into the parking lot, the facility shut down for whatever reason. So just being very, very flexible. And then understanding that many departments are within one facility. So you have security, you have behavioral health, you have treatment. So sometimes you have addictions treatment team members that may be a part of the Department of Corrections, or they may be from an outside agency that's providing services within the facility. And then you also have these phenomenal health services staff. So nurses and docs that we work with at Coffee Creek are great. And then obviously PREA that I mentioned. Okay, so I'm going to turn it over, and Morgan and I are going to do a bit of a Q&A before we open it up to questions from everybody that's on the call. So just in full disclosure, we developed some questions that we thought you guys might be interested in, and Morgan had the questions ahead of time. So I will keep monitoring for time, and then Meg, tell us when we need to open it up for questions from our webinar participants. So Morgan, if you can unmute yourself and we'll test your your audio.
Can you hear me?
Yes.
Okay, good.
Great. Oh, it's all working well.
Nice.
So thanks for being a part of this. I'm so glad you're here with us. You work at Bridgeway in Marion County and Salem, and maybe we could just start off, will you tell folks on webinar a little bit about yourself and how you became a peer mentor?
Yeah, I became a mentor because of my own recovery. It started when I was sentenced to prison for 5 years. Prison actually saved my life. And since then, I've had a passion for working with women in the correction system. A couple years after I was released, I decided to go to school to be a drug and alcohol counselor.
Yeah.
I started working at Bridgeway while I was going to school as a mentor, and shortly after I got my CDC, I realized quickly that I didn't want to become a drug and alcohol counselor because I love being a mentor. However, I keep my CDC because I'm able to do a lot of things that the counselors do, like assessments and groups and things like that.
That's great. Great. Thank you. So tell us a little bit, how's working on ROAR project different from the work that you were already doing at Bridgeway?
Before ROAR, I worked with women coming out of Coffee Creek, but I didn't have contact with them until they were already out. With ROAR, we get to build relationships with the women prior to them releasing, which is helpful because we're able to get an idea of the needs that they have to better help them when they're out.
Yeah.
And also they feel more comfortable because we've already started building a relationship, so it's easier for them to call or reach out.
Cool.
But the cool thing is, when I first started working at Bridgeway, my supervisor at the time, Tina, and I would always talk about how cool it would be to go into Coffee Creek to build relationships with women prior to getting released, and now we're able to do that with ROAR.
Awesome. So can you tell me how the women are different in terms of what their needs are, or do you change your approach when you're working with them?
Every woman's needs are different. The first few visits, I'm able to get an idea of what their biggest barriers are going to be, and the kinds of things to focus on when they get out. It could be housing, clothing, job. Everyone's so different.
And do you find that some women are more open to your help or getting help from you?
Some women engage easier than others for sure. There are times where it feels like we have to work harder than them to get them to engage, but that's okay too.
Yeah. And then what kind of ways have ROAR participants asked for your help or support, or like what kind of questions do you get from the participants?
For a lot of the women, it's just been really support around the adjustment of being out. For some, it's easy and no big deal, and for others, it can be really hard once released.
Mm. Can you say more about like what those challenges are about getting out of prison?
Sure. Again, everybody's different, but it's like a lot's changed. Your family and your children have gotten older. Life has moved on without you, and you're just trying to figure out where you belong in all of it.
It's a really good point. You know, I think back as about a year ago, maybe longer, you were on a interview with OPB Think Out Loud, and one of the things you said that was really stuck with me was like when you got released, how you felt like an alien, and I'm wondering if you could say more about that.
Getting out of prison, I didn't realize how hard it was going to be when I first got out. My mom and my aunt took me to a restaurant to eat, and when we went inside, I was looking at the menu and I couldn't order. I had so much, it was so much anxiety because there was all these choices, and it's been how many choices there were overwhelming. I had to sit down and have them order for me. It was also hard, like going into stores. I felt like I didn't belong there. I didn't know how to interact with people. I felt like I had a sign hanging above my head that said I just got out of prison.
Oh, Morgan, it's so overwhelming. My gosh.
It's very overwhelming.
You know, you work in Bridgeway, so you have like addictions treatment. We have that federal confidentiality, but then in research we have like the human subjects protection for our participants. So how is that different, or how is this different from the usual work that you do with Bridgeway, or is it?
Well, I think the biggest difference is with ROAR, we don't use the participants' names even when we're documenting in REDCap.
Okay.
And in our clinical records at Bridgeway, we're able to use our client's name when we're charting. It's an adjustment it's just an adjustment identifying people differently between the two charts.
Got it. And then is anything else different?
We had a lot of trainings prior to starting ROAR. We had 2 weeks of intensive trainings on the topics related to research and working with people in corrections. Also at Bridgeway, I'm able to talk to my coworkers about like the involvement in the different programs our clients are in. But with ROAR, we can't do that. We have to protect their status as a ROAR participant. Yeah,
got it. Good. So let's do a little segue then, because that's good to talk a little bit more about role definition. So, you know, you work as a ROAR mentor on the study with the team at OHSU, and then with Erin and I at CoMagin. And then we meet weekly, and you have a lot of contact with Erin around like where women are and their status. But then you're also working as a mentor at Bridgeway. So it's a bit like you're maybe playing two different roles simultaneously. Is that right or no?
It doesn't really feel different to me because I'm used to working with corrections clients. We do staff meetings with parole and probation where we staff clients, talk about any concerns, or if a client has new contact information that one of us didn't know about, we share that. I'm doing what I normally do at Bridgeway with the women once they're released.
Okay, got it. How about, would you tell us maybe a couple stories, success stories with some of the ROAR participants, and some of the ones that stick out for you?
Yeah, the first one that sticks out was my first participant that I worked with. She released from Medium. She had a tough relationship with her oldest daughter, or lack of relationship. Her daughter was living with her sister. The daughter didn't want anything to do with her mom at all. But before the participant was released, it ended up being like a flyer for a camp for kids with parents who are incarcerated.
Oh, wow. Yeah.
And so she sent information to her sister, and her daughter was like willing and good, okay to do that.
Uh-huh.
And she went, and like the lady I was working with, like she's came to terms with like, it is what it is. I'll take what I can get from my daughter.
Mhm.
And if we have a relationship, it'll be on her terms. And then the participant ended up seeing her like 2 days out, and then she just started seeing her all the time. Their relationship, just started forming, and now she has her daughter like every weekend and sees her throughout the week. The participant has completed the study and treatment with Bridgeway, and she chooses to stay on Vivitrol, so she's been on it well over a year. She has a job, and she's doing amazing in the community.
That's a great one. That's a really good one.
Yeah.
And is there wow, I love that. Having a relationship with her daughter, that's very cool.
Yeah, it was huge.
Is there another one?
Yeah. So one of the women that were released right before the pandemic hit,
Yeah.
she's never been in recovery before. She's been in her active use her whole adult life. She never had a driver's license, but she did always drive. She got released from prison, decided to start school to become a drug and alcohol counselor. She was nervous because she struggled in school in the past, never really went. However, she surprised herself and has gotten complete straight A's and made honor roll. She was supposed to graduate treatment Bridgeway already, but because of COVID, she hasn't established a clean and sober support system really outside of her family and us.
Yeah.
So she's not ready. She's really not ready. She wasn't ready to complete. She's like, I don't really want to be done, because she's still benefiting from the extra supports. So she's doing really well. She's got her driver's license for the first time. She bought her own car. She continues to do the next right thing. She had a significant other who was also incarcerated, and it was not the best relationship. She started building healthy boundaries with him, and now she's no longer in that relationship. So she's just made huge
progress. Wow. That's very cool.
Yeah.
I love that she underestimated herself, and now she's a straight A student, of course, right?
Yeah, she's pretty
excited. So cool. So, okay, you got to tell us about when something went really wrong, or you were just like, oh man, I just did not anticipate this.
Well, the one participant got out right when the pandemic, like the shutdown started.
Oh, okay.
She had housing completely lined up at transitional housing. But the day that she got out is when everything went on shutdown, and they decided at the transitional housing, nope, we're not taking anybody new right now. And so she had nowhere to go when the day she was released. I ended up finding her temporary housing at our Bridgeway New Options. But by that time, her ex, who picked her up, already rented a hotel room, so she felt obligated to go with her.
Yeah.
Her assessment was the day after she was released. She had her intake that day, but her assessment was the day after. And that's the day that we all got sent home to work from home because because of the shutdown. And so unfortunately, like telehealth and all that was not set up like the day we went home.
Right.
And so she wasn't able to get her assessment done or have anything set up. So we didn't have anything lined up for her. I would call her. I'd call all the time, and it was hit and miss being able to get a hold of her, and just nothing lined up for her. The last time we spoke, she said she knows she needs treatment, but she can't do it right now. She needs to focus on employment and housing. She had a boyfriend and was living in a hotel. It was horrible. I couldn't imagine getting out of prison, not knowing where I was going to live, and coming out to a world that is completely shut down after, I think, 4.5 years she was.
I know, I'm with you. And I remember staffing this one. I think you did your due diligence and just everything that I'm sure others can relate to. You know, when the pandemic hit, we all just tried to pivot the best we could. And heartbroken
for her.
Yeah, I know. Okay, so here's my magic wand question. If you could change one thing about your work or working with women or addictions treatment in general, like what would it be?
Um, I think I was fortunate when I was released. I had a support system. I had a loving and supportive family.
Mm-hmm.
I don't know what I would have done without them.
Mm-hmm.
Some women get out and they don't have anyone clean and sober in their lives to even turn to. I wish all women had a support system when they got out and had clean and sober living. Um,
Agreed.
I also wish it was easier for women to get their driver's license back. It's been challenging because the guidelines to get your license, the hold off your license is different in every city. So
Mm-hmm.
not having a license can be a huge barrier for them to make their appointments, job interviews, treatment, make it to their parole and probation appointments when you have to rely on the bus system.
That's right. I mean, geez, it is just one of the biggest barriers. I mean, between housing and support and transportation. Yeah,
Yeah, it's huge.
it's really hard. Yeah, thanks for telling us about that.
Yeah.
Okay, so let me ask you kind of last question. Is there anything else that you want the participants of the webinar to know, either about yourself or about ROAR, about recovery or anything?
I think the hugest, like, I wouldn't feel right without saying it because it's been just the hugest part of my life.
Mm-hmm.
Prison and running saved my life. When I was incarcerated, when I first went in, I was 23 years old. I gained 50 pounds. I started running.
Mm-hmm.
When I first started running, I couldn't run a lap. I can remember when I ran my first mile. By the end of my sentence, I was running almost 10 miles a day.
Wow.
I'm grateful I was able to start running inside prison because I'm not sure I would have stuck with it. I would have given up or frustrated because I didn't get fast enough results.
Yeah.
Weight
Yeah.
gain was always a big trigger for me. I'm grateful I was able to get that niche while I was still incarcerated.
Yeah.
And I was in there long enough to make it a part of my everyday life. Running helps me regulate my emotions. I was young when I started using, so I had minimal coping skills, and running worked for me. So I held on to it for dear life. Physical fitness has been such a huge part of my recovery. I know it can work and be a great tool for women.
Yeah.
So I try to push it on a lot of the women I work with. My
Yes.
Bridgeway is awesome, and they let me think outside the box and help me, supported me doing an exercise group when we were doing in person. So normally, like for the last 6 years, I've done an exercise group twice a week with the women just to help encourage them to be active and get their endorphins going and try to get them to start feeling good about themselves and have something else to do with their time.
Yes. Yes. That's fantastic, Morgan.
Thank you.
Thank you. I just want to say, a couple things. I want to say thank you for just being willing to be a part of the webinar and sharing your own experience of what it was like for you and what you're giving back to others through your work as a mentor on the WAR program. And I want to say, you and Ivy are like the heartbeat of the pilot project. Of this project. You guys are really, you're the glue for everything. And we are so grateful to you both. And we certainly could not have done it without y'all. So thank you.
Thank you. I love being part of it.
We love having you.
Thanks.
Okay, Meg, I think we're done with the Q&A, and I didn't know if you wanted to open it up for questions or next steps.
Yeah, so let's, we've gotten a couple of questions, so I'm gonna jump ahead to the most recent one just because it's directed at Morgan and we just heard from Morgan. So someone asked you, Morgan, is it standard that housing is secured prior to release, or are some people released homeless?
I think they try to make it standard. This is the first time, and it was just because everything was shut down. But there are times where women get released to going to a shelter. They don't always have a solid plan, but I think they aim for it, but unfortunately it doesn't always happen from what I see.
All right, next question is, this one came early on when Aaron was speaking, so perhaps Aaron can address this one. What does passing a criminal background check entail when over 80% of recovery community members have lived experience with the criminal legal system?
Sure. Yeah, passing background checks can be a huge barrier, and it's something that comes up in a lot of the assessments that we do when interviewing people that are delivering services. So and Christy, I might pull you for the specifics, but it really varies by state, and it also varies within state. So there might be multiple certification bodies within a state, which is something that happens in Oregon, and they might have different levels of requirements for what's included in the background check. Christy, do you want to share some of those specifics?
Sure, if I can remember them all. So, you know, specifically here in Oregon, we have this kind of overarching under the traditional healthcare worker whatever umbrella for Oregon, and under that is, you know, peer support specialists and peer recovery mentors and doulas and all the folks. So you have peer support specialists that are focused on addiction specific or maybe mental health, and then through the Mental Health and Addiction Counseling Certification Board of Oregon, they provide the CRM. So both Morgan and Ivy have their certified recovery mental test. For folks that may have a pretty lengthy criminal background check, some folks decide to go through MACBO's certification process because the criminal background check standards are a little bit more lenient. I think they use what's called like the Big Six. So I think what excludes people for certification are things like murder, rape, you know, child abuse, those kinds of big ones. So, and whereas the state provides one, the state of Oregon provides a certification, and the criminal background check is a little wonky, and I think folks have a harder time getting through that one at times.
Okay, another question, does anyone know what the median income for a peer support specialist is?
Yeah, so in national data in the literature, it ranges from $10 to $20 an hour on average. Just recently, we partnered with the Mental Health and Addiction Association of Oregon here, and they were doing a needs assessment of peer-delivered services funded by Oregon Health Authority. And we found that the average income was $18.26 an hour. That's hot off the presses. We just submitted that report to OHA.
Interesting. A question for you, Elizabeth. Are all the studies that were referenced today in that protocol document that you shared in chat?
Yes, they are.
Great. I'll include the link to that protocol document in the email I send out later today, so everyone has that handy.
And then my email is on the screen, and if anyone has difficulty finding a reference or has more questions, I'm happy to talk with you one-on-one.
Great, thank you so much.
And Meg?
Yeah.
This is Christy. The other thing that I would say, Morgan, Aaron, you might want to chime in about this, is that, you know, the information that Aaron presented on specifically is a article that she led that has been submitted to the Journal of Addiction Medicine. Do you want to say anything more about that, Aaron?
Yeah, sure. So it's under review. It's a narrative review that's under review by Journal of Addiction Medicine. And I'd be happy to share the references from that narrative review with Meg to distribute to the group, if that would be helpful.
Yeah, that would be great.
Sure.
Okay, cool. Okay, next question. What is the difference between a peer support specialist and a mental health aide? Anyone?
That might be for me, and if other people want to respond. A mental health aide, that the certification in Oregon for an individual who serves people that are in recovery from mental health is a peer support specialist -- mental health. So I'm wondering if mental health aide might just be another term for that certification, but I'm not sure if others on the panel know.
There's also maybe a related question where someone asked if any of your peer support specialists are trained in both SUD and mental health concerns.
Yeah, so this is Christy. Both Morgan and Ivy are trained in co-occurring disorders, albeit that I think both Morgan and Ivy hold both their certified recovery mentor certification, and they're both CDC certified alcohol and drug counselors within the state of Oregon. So they've had extensive training around co-occurring disorders.
Great. Okay, we also got a question. Someone was wondering if anyone knows what the shelf lifespan for Narcan is. No, that's probably something you might be able to just Google and find out if you want to give that a shot. Next question is, one of the requirements for receiving naltrexone is that women need 5 to 7 days of abstinence from substances before beginning the injections. How do they achieve this if they're still in the throes of their addiction? Anyone?
Meg, can you repeat that question?
Yes, the question is, one of the requirements for receiving naltrexone is that women need 5 to 7 days of abstinence from substances before they begin the injections. How do they achieve that abstinence if they're still in the throes of their addiction?
I'll take that question. It's really an important one. So within Coffee Creek Correctional Facility, all of the women incarcerated there are serving sentences of a year or more. So in theory, they would be free of substances prior to their release. Of course, people use in prison. We have planned to, we planned on purpose to do the education visit around extended release naltrexone several weeks before their release, so that women who are using and need to address that prior to release have time to reach out to health services staff, behavioral health staff before they're released and before they would get that injection. I will say that of the first 55 women who we've enrolled in the study, none were currently using an opioid. So it hasn't come up for us yet in the prison setting. This is a much, much bigger deal for folks who are working in jail settings, and detox protocols need to be worked in directly to any kind of pre-release programming that involves extended release naltrexone.
And this is Christy. Just to add on, I would say that for folks in community that are not involved, obviously in rural community corrections, like you would use a different medication. So,
okay. Looks like the last question for today is, in Washington, we oddly don't have a peer credential, only a peer certificate, and then peers are credentialed as agency affiliated counselors. Some folks are afraid that if we create a peer credential, it will require volunteer recovery coaches to get credentialed. Was this a concern in Oregon when the peer credential was established, and has that problem materialized?
I don't know all the historic, this is Christy, I don't know all the history behind the establishment of the CRM. I can tell you there is a recovery requirement of 2 years for individuals that are seeking, that identify as recovery, that are seeking to be a CRM. I'm not sure if I answered the question.
I think so. Okay, has there been any progress made getting Suboxone or any other treatment medication for OUD into correctional facilities in Oregon?
Yes, 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 which is exciting. Can you hear the excitement?
Yeah.
So right now, there is a protocol in place for anyone entering the state prison system in Oregon to continue on buprenorphine or methadone if they come in and are already on that medication. Everything is really distracted by the pandemic crisis right now. But I know the long-term goal is to expand access to MOUD in the prison system. And there are multiple counties in Oregon. The county jails are totally separate from the prison systems. We have multiple counties that start people on MOUD when they enter jail. Usually it is part of a detox program, and it is a short stint on buprenorphine to help with the detox. However, programs are expanding to allow people to continue if they enter jail on buprenorphine or another form of MOUD. I
Right.
know county in particular that is in the process of applying to become an opioid treatment program, so they can do methadone in the jail.
Okay, so I want to be respectful of everyone's time, and we are right at 11:30, so I am going to go ahead and conclude the webinar for today. So watch your inboxes later today for an email that will have some extra goodies in it, some links to the protocols and maybe some extra references, and also a link to the slides and a recording of this webinar will be in that email as well. Thank you everyone for coming today, and thank you to our speakers. This is really wonderful, really appreciate it.